Hi friends, Pradeep Pendiala. Today I am going to talk about basic life support and advanced cardiac life support to save a person from sudden cardiac arrest. This is one of the most important lessons you can ever imagine to have learned. You're saving a life, somebody's life, and that's in your hands. Just by knowing few important things, you can save your life. So kindly pay attention. Friends, the basic life support and advanced cardiac life support, the basic difference is that in advanced cardiac life support, we use drugs and defibrillator. Whereas in the basic life support, we just resuscitate a sudden cardiac arrest. Normally, we follow American Heart Association guidelines. They publish it every 5 years after International Liaison Committee on Resuscitation ILCOR meeting. This would be very, very interesting because every 5 years we keep giving fresh guidelines. The definitive treatment for ventricular fibrillation is definitely electrical defibrillation. Friends, you must know that if at all there is a cardiac arrest, 80% of chances are because of ventricular fibrillation. And for that, the definitive treatment is only ventricular electrical defibrillation. So this is most often performed using automated external defibrillator, AED. If an AED is not readily available for defibrillation, brain death is likely to occur in less than 10 minutes. So if you reach a place where a sudden cardiac arrest has taken place because of ventricular fibrillation, which is the 80% of possible chances of being the etiological cause, the chances of revival is zero because every minute delay in giving a defibrillation shock for ventricular fibrillation decreases the chances of survival by 10%. So if you have done electrical defibrillation after 10 minutes, the chances of revival is almost zero. So now you can understand how important is that. So conventional manual CPR combined with chest compression with rescue breathing can provide up to 33% of normal cardiac output and oxygenation. So the external cardiac massage can be done, the normal basic life support without defibrillation. But normally that is for asystole or for pulseless electrical activity. So friends, this is the basic difference of the entire thing. Normally, what happens, the immediate recognition of cardiac arrest is essential to initiate the emergency medical services, that is known as EMS. You can call 108 service or 901 if you are in foreign countries, in US and all. But normally in India, 108 is the emergency medical service, can be easily contacted through mobile phone or a landline. So you must remember that. And in this era, you must know to call 911, not 108 in foreign countries. So what is this done? What you have to do simultaneously begin CPR by first performing chest compression, followed by opening the airway and delivering rescue breath. That is known as CAB sequence. Compared to what we used to do much earlier, that used to be ABC, airway, breathing and compression sequence. The hands are placed on the lower half of the sternum and chest compressions are begun at a rate of 100 to 120 compressions per minute. The goal is to depress the sternum to a depth of at least 2 inches while avoiding excessive depth of compression. The chest wall should be allowed to recoil fully on the upstroke to maintain coronary artery perfusion pressure. 30 compressions are performed followed by a brief pause for 2 rescue breaths. Because of the critical contribution of chest compression to coronary artery perfusion, interruptions in chest compression should be as minimal as possible. So, friends, I told you the basic thing which you must do while saving a life. Now, you must know what are those American Heart Association guidelines which they keep advising you every 5 years change. Like the last had occurred in 2010, then 2015 and 2020 guidelines. That is the latest guidelines. So we must know what are those guidelines. And firstly, I'll tell you the basic difference between 2010 and 2015 guidelines. The chest compression. In 2015, not more than 2.4 inches, 6 centimeter should be compressed when you are doing CPR. Whereas in 2010, at least 2 inches, 5 centimeter, no upper limit. But now they are saying you should not compress it more than 6 centimeter. That is equivalent to 2.4 inches. Compression rate. Now the latest is 100 to 120, but not more than 120. Earlier it used to be 100 per minute. Breath rate 10 per minute. That means every 6 seconds you must give one breath. Earlier it used to be 8 to 10 minutes. Vasopressin. Now they no more use vasopressin. Strange but true. What they have found, vasopressin offers no advantage over epinephrine in cardiac arrest. And moreover, they wanted to simplify the procedure of cardiac resuscitation rather than complicating it. It's best to give epinephrine or adrenaline every 3 to 5 minutes. That's the best course of action. And if that is also not working, you have to give amiodarone, 300 milligram IV bolus followed by 150 milligram IV. That's how it has to be done. Besides CPR, cardiopulmonary resuscitation by external chest compression, and as I had said, defibrillation with cardiac shock for every case of ventricular fibrillation or pulseless ventricular tachycardia. We normally give that. So I was talking about the differences between 2010 and 2015 guidelines. The earlier activation at second step after assessing responsiveness. Now flexibility at multiple stages of CPR has been advised. Assessment of breathing and pulse should be simultaneously done now as per the latest guideline. Earlier it used to be separately. Targeted temperature management. Earlier it used to be 32 to 34 degrees centigrade, but now it's been recommended to keep the temperature around 32 to 36 degrees centigrade for at least 24 hours. Extracorporeal circulation. Earlier, less liberal approach towards extracorporeal circulation, now employed early. So organ donation, now more emphasis is being given compared to earlier times. Always remember 1 milligram to be repeated every 3 to 5 minutes adrenaline during CPR. You have to give 1:10,000 dilution. Normally adrenaline is provided 1 ml ampule. You have to dilute with 9 ml of saline or saline, and so that it becomes 1:10,000, and administer it IV, intraosseous or even endotracheal. If you are giving endotracheal, it should be at least double the dose of what you are expecting to give in IV to have proper effect. IO, intraosseous and IV doses are same. So that you should know. And normally when a newborn pulse check is done, it is auscultation of the heart. Infant, we check at the brachial or femoral pulse. Child, carotids are normally felt, and adults, as you know, carotid or femoral. Compression area, lower 1/3 of sternum in a newborn, whereas in an infant, it is mid-sternum line below the intersection of the intermammary line, whereas in a child, mid-sternum line below intersection of intermammary line, whereas in adults, lower 1/3 of sternum, 2 finger breadth above the xiphoid. Compression method, 2 thumb with encircled chest in a newborn, whereas an infant means 0 to 1 year aged. 2 to 3 fingers we use for compression. In a child, heel of one hand, whereas in adults we use two heels. Heel of two hands, one locked over the other, kept straight and pressed. To the extent I said 100 to 120 compressions per minute. Compression in the newborn infant should be started if heart rate less than 60 are noticed. So don't wait if the heart rate to still go down or it becomes asystole. Then you start compressing in a newborn. Newborn, you must start doing compressions immediately if the heart rate is less than 60 per minute. As I've said, the sternal depth also is very important. Newborn, it should be 1 inch. Infant, 1.5 inch. That comes to around 4 centimeter depth. And a child, 2 inches. That means 5 centimeter or 1/3 of anteroposterior diameter. And the adult, it is 2 inches or 5 centimeter. Should not exceed 6 centimeter. That's very, very important. That is more than 2.4 inches should not be exceeded. There is no second thoughts about it. And how the defibrillation is done with this defibrillator. Defibrillation is done for ventricular fibrillation, pulseless ventricular tachycardia, or polymorphic ventricular tachycardia. Defibrillators have been classified as monophasic or biphasic. The present available defibrillators are all biphasic. So that is what you should know, and even if the defibrillator could be given manual or automated, that is AED, automated external defibrillator. Now all defibrillators which are available, even automated external defibrillator, are always available now is biphasic. So let me concentrate on the things which are the latest. That means 2020 guideline. Very, very interesting. The new guidelines have given lot of importance to the bystanders. Very, very important thing. We must know the why the guidelines have advised lay persons immediately start CPR in these situations rather than wasting valuable time. Lay persons should not bother checking for a pulse if a patient suddenly collapses. Now we have given, in India, a lot of work has been done in calls, compressions only life support. So we must know the latest guidelines are encouraging very much layperson should immediately start CPR rather than checking a pulse. They are being trained in lakhs in India in administering calls, and every person a lifesaver. That is what is being done. And that's because there's one more thing. Why they should not look for pulse layperson? Because they are not much used to locating pulse, especially in an emergency situation. That's why, in addition, they should start compressing the heart if they find a sudden cardiac arrest. So, the new research demonstrated that the risk of harm is low if it turns out to be the patient not experiencing cardiac arrest. So, best is just start compressing. The guidelines reaffirms advice recommend the layperson risk care immediately start CPR in this situation rather than wasting time, valuable time looking for a pulse. That's the thing which has been told in the latest guideline. Then in the new 2020 guidelines also recommend that CPR training should start in middle or high school level to instill sense of confidence and familiarity at young age, and that lay rescuers learn to administer naloxone to individuals experiencing drug overdose. The many cases have been found because of drug overdose, and naloxone really works. So we have given a free hand for rescuing such persons by administering naloxone. Earlier, naloxone was not much used, but the new guidelines are definitely encouraging. The new guidelines recommend that lay persons training should start as early as possible. And earlier, we used to think double sequential defibrillation could be helpful, like use of two AED machines to deliver two shocks at once. But recent research does not provide clear and conclusive evidence and in any patient. Hence, it is not recommended to give double sequential defibrillation. Early administration epinephrine has been very much encouraged. In 2020 guidelines, AHA guidelines make stronger and more specific recommendations for use of epinephrine as soon as attempts at defibrillations fail, based on updates from last year showing that epinephrine should be administered every 3 to 5 minutes for as long as resuscitation continues. So I'm very hopeful that this was very, very informative. Vasopressin has been removed rather than that, because to make it simplified, they have given simple 1 epinephrine, or it's also known as adrenaline, 1 milligram every 3 to 5 minutes. That would save a life, along with constant compression at the rate of 100 to 120 per minute without interruption. Don't waste time for putting pads of defibrillator, and continue the compressions with minimal restrictions or discontinuation without interruption. That would save the person, and you could save a person and resuscitate a person with lot of positive results. Thanks for patient listening. This is Colonel Pradeep Pindiala, Professor of Anesthesiology at ASRAM Medical College, Eluru city of Andhra Pradesh, India. Until next time, take care. Bye-bye.